All right. I will call this 25th public meeting of the Presidential Advisory Council on Combating Antibiotic-Resistant Bacteria to order. This meeting is a culmination of 6 months of hard work by our Global Antimicrobial Resistance Working Group that has worked tirelessly to develop this report in a very tight timeline. We want to thank the working group members for being actively engaged and thank the outstanding PACCARB administrative staff for world-class support in our efforts. Today, we're pleased to share that report and finalize our efforts. We'll also be covering a number of other important topics, including the advocacy and importance of patient voice in pushing change related to antimicrobial resistance. We'll be getting an update on antimicrobial resistance in companion animals, discussing the complexities of antimicrobial resistance in conflict zones, and finishing up with a panel on unequal exposure and unequal risk. As we rapidly approach the UN General Assembly high-level meeting of antimicrobial resistance in September of this year, this new PACCARB report will provide recommendations to the US government and others involved in those discussions. These recommendations will also provide a resource to the USG as they start the process of developing the next National Action Plan, and we're pleased to be able to share those publicly today. With that, I'd like to turn it over to my co-chair, Dr. Jason Newland, for a quick introduction.
Yeah, thanks, Paul. I want to just first express my gratitude to our wonderful PACCARB staff. I'd like to also the thanks to the awesome work group of the AMR work group, that is Global AMR work group, that has spent a lot of time and effort over the last 5 months to put this together. And then a big thanks to all the presenters that are going to be with us over the next day and a half. We look forward to your comments. We look forward to the discussion. I'd just like to highlight that the work done by PACCARB matters. Some might sometimes think it doesn't, but it definitely matters, as many of the reports have been germane to future things that have occurred. And I'd like to just to highlight that when we look at H5N1 that's going on, we have a most recent report out that was in our last report that suggested, how do we plan for the next pandemic? Now, I'm not saying that this is the next pandemic, but I do want us to be mindful that the work done here matters, and we appreciate all of you for the efforts that you have done and look forward to more fruitful discussions.
All right, I will now turn it over to Dr. Jaman Musmar for our rules of engagement and participatory roll call.
Thank you, Drs. Plummer and Newland, and we welcome everyone to the 25th meeting of the Presidential Advisory Council on Combating Antibiotic-Resistant Bacteria. We're delighted to have you all with us today, both in person and the majority in virtual land. I am the Executive Director and the Designated Federal Officer for this Advisory Council, and I would like to thank all of our presenters, attendees, and stakeholders for joining us today, especially those that provided public comment. All public comments submitted to the CARB at HHS.gov mailbox has been provided to the Council, and we look forward to the in-person comments that will be provided again today. A little bit about the Council. This Advisory Council was initially established via an executive order in 2014, so we are going 10 years strong since then. And then in 2019, we were codified into legislation through the Pandemic and All Hazards Preparedness and Advancing Innovation Act, and this formally reestablished under the statute as of September 2nd, 2020. The goal of this Advisory Council is to give the Secretary of Health and Human Services advice and recommendations to improve the programs and policies related to antibiotic resistance that would contribute to the overall health of our country. To accomplish that mission, the Advisory Council strives to address the issues related to antibiotic resistance through a One Health approach, which is evident in all of our proceedings and our products and our membership. Before we start, there are a few things you should know. First, this meeting is being recorded and will be available on our website, hhs.gov/PACCARB. Second, the Advisory Council is governed by the Federal Advisory Committee Act, or FACA, where the majority of the work of this Advisory Council, including information gathering, drafting of reports such as the one today, and the development of recommendations, is performed by designated working groups who in turn report to the full Council for deliberation and final vote, which will also take place today. Regarding the conflict of interest rules, all 15 voting members of the Council are considered special government employees, or SGEs, and are subject to conflict of interest laws and regulations. The 12 regular government employee members, or RGEs, representing different agencies and departments on the Council, have also been vetted for any conflicts of interest. Lastly, as mentioned by our chairs, I'd like to thank my team sincerely for their efforts to support the council and plan for this meeting, especially Ms. Sarah McClelland, Ms. Haley Krem, Dr. Zaina Francis, Ms. Lauren Plain, and the team now at Deloitte, formerly known as Griffin Scientific. And as always, our logistics master, Ms. Jennifer Adana. I will now go through a roll call for all council members. Please let us know if you're present by stating here. For alternate representative members, please identify yourself and provide the name of the principal you are representing today. Beginning with our voting members, Dr. Paul Plummer.
Present.
Our Vice Chair, Dr. Jason Newland.
Present.
Dr. Stephanie Black.
Present.
Dr. Claire Burbick.
Present.
Could you turn on?
Present.
Thank you. Dr. Virginia Fate.
Present.
Dr. Susan Wong.
Present.
Thank you. Dr. Jenny Kwan.
Present.
Dr. Brian Lubers.
Here.
Thank you. Dr. Lynn Marks.
Present.
Sir Armando Nahum.
Here.
Dr. Payal Patel.
Here.
Dr. Robin Patel.
Here.
Dr. Joni Sheftel.
Here.
All right. Dr. Julie Simzak.
Here.
And Dr. Tom Whittam.
Here.
Thank you to our SGEs. Moving on to our liaisons, Dr. Carla Houston for the American Association of Extension Veterinarians, I know could not be with us today. Next, we have Dr. Padmini Srikantia for the Bill and Melinda Gates Foundation.
Present.
Thank you. Miss Emily Wheeler for Bio.
Present.
Thank you. Dr. Francisco Zagmid for EpiExa Analytics.
Here.
All right, Dr. Lucas Pantaleon for the National Institute of Animal Agriculture.
Here.
Dr. Libby Dodds-Ashley for the Society of Infectious Disease Pharmacists.
Here.
And Dr. Tim Jinks for the Wellcome Trust.
Here.
Thank you. Now to our RGEs, or regular government employees. Please let us know if you are covering for the principal representative. For the USDA, Dr. Jeff Silverstein. Anyone for Dr. Jeff Silverstein? All right, Dr. Sarah Tomlinson. Dr. Kiss Robertson Hale.
Good morning. Gamola Fortenberry.
Good morning. I know that Dr. Chelsea Shively's on the line. I think we saw her, and I know that she's representing. So I just want to state for the record, Dr. Chelsea Shively, you're here. Oh, you're on mute, but we can't hear you, but we see you. So we'll say yes. All right. For the Department of Defense, Dr. Paige Waterman.
Here.
Thank you. On to HHS for the Administration for Strategic Preparedness and Response, Dr. Chris Houchins.
Present.
Thank you. For the Agency of Research, Healthcare, and Quality, Dr. Melissa Miller.
Here.
Thank you. For the Centers for Disease Control and Prevention, Mr. Michael Craig.
Here.
Thank you. For the Centers for Medicare and Medicaid Services, Dr. Sherry Ling. For the National Institutes of Health, Dr. Dennis Dixon.
Here and present.
Welcome. For the Office of Global Affairs, Dr. Pat McDermott.
Here.
Thank you. And for the Food and Drug Administration, Dr. Bill Flynn. Covering for him is?
Ribhi Shower.
Thank you, Dr. Ribhi Shawar. And for the Environmental Protection Agency, the Office of Research and Development, Dr. Jay Garland. Are you there?
Yes, I am.
Fantastic. Thank you all for joining us today for this meeting. I'm going to switch gears a little bit because I mentioned that the council was established back in 2015 via the executive order in 2014, but we just recently learned, and it's with a heavy heart that we announce, the passing of Sherry Dornberger. She was our executive director of the National Association of Directors of Nursing Administration, NADANA, and she was one of the very first council members representing nurses when we were first established. So she served a 4.5-year term on the PACCARB until the June of 2019. And we want to acknowledge her passing, and we honor her family, and we send her all of our blessings. All right. So with that said, before we begin, we're just going to go through a few housekeeping items to remember, since everybody has a microphone and we are virtual. I ask that council members who wish to ask a question or have a comment to use their name cards by propping it up, it vertically, or raise your hand. The moderator for each Q&A session will call on you. Once you've been called on, please remember to unmute the microphone at your seat before speaking, and then mute yourself following your comment or question. All right, so now we are going to start off with our opening remarks. I have the pleasure of introducing Lois Pace, the Assistant Secretary of Global Affairs for the Department of Health and Human Services. Ms. Pace is responsible for advancing the U.S. international health agenda and setting priorities and policies that promote American public health agencies and interests worldwide. Ms. Pace oversees HHS's engagement with foreign governments and international institutions, as well as policy-making bodies such as the G7, G20, the United Nations General Assembly, and the World Health Assembly. Previously, she served as president and executive director of the Global Health Council and was also a member of the Biden-Harris Transition COVID-19 Advisory Board. At the Global Health Council, she advocated for increased federal investments in global health in the face of budget cuts to the U.S. Centers for Disease Control and Prevention, the United States Agency for International Development, and the World Health Organization. Prior to her role there, Ms. Pace spent over a decade working with community-based organizations and grassroots leaders in countries across Africa and Asia on campaigns calling for person-centered access to health. Due to Ambassador Lois Pace's schedule, she will not be joining us here, but has pre-recorded her opening remarks. I now ask that you please turn your attention to Ms. Pace on the screen.
Hello again. I am honored to welcome everyone to the 25th public meeting of the Presidential Advisory Council on Combating Antibiotic-Resistant Bacteria, and I regret I could not be in there in person with you all. Today, we gather with a shared commitment to address one of the most pressing global health challenges of our time, the rising threat of antimicrobial resistance. We all know that AMR is one of the most important infectious disease threats of our time. In fact, last week, I spoke at an event at the French Embassy and was able to meet with a survivor there. I heard her stories, and that underlined what we all know, that we must act now. The urgent threat and the global threat of AMR demands political visibility and strategies that leverage and apply coordinated action at all levels with the One Health approach. The U.S. has always been a global leader in the fight against AMR and has demonstrated a track record of progress protecting people, animals, and the environment from the threat of AMR, both domestically and internationally. Later this month, Secretary Becerra will be leading the delegation to the World Health Assembly in Geneva. During the World Health Assembly, we will not only consider a resolution to advance efforts on AMR, but Secretary Becerra and I will speak at multiple events on this issue. Our U.S. delegation to WHA, which includes HHS agencies like CDC, FDA, and NIH, as well as other U.S. partners such as state and USAID, will participate in many other AMR events to help highlight how critical the effort is across our administration. However, we recognize the remaining challenges and that more can always be done. This remains especially true after the setbacks in progress due to the COVID-19 pandemic. This council, established in 2014 by executive order, is one of the most valuable mechanisms the United States has to monitor progress, assess gaps, and recommend solutions that inform effectively implementing the National Action Plan for Combating Antibiotic-Resistant Bacteria. Today marks another important milestone as the Council convenes to discuss and adopt a report containing its crucial recommendations on how U.S. government agencies can lead global AMR efforts for sustained action, both domestically and internationally. While we are focused on the World Health Assembly, we continue to prepare for the second high-level meeting on AMR at the United Nations General Assembly. We're preparing for the negotiations on the political declaration, which we hope to land in September. In November, countries will gather for the fourth Global AMR Ministerial Meeting. We know all these international moments are critical to focus attention on AMR, but we must use them to garner commitments and targets that are ambitious and actionable while rooted in science. These efforts can galvanize more effective, coordinated, and sustained and multi-sectoral efforts. With all the attention we have this year and stakeholders highlighting the critical linkage between AMR and other global health initiatives and challenges, such as tuberculosis or water and sanitation, we can drive sustainable solutions to AMR. So as you can see, your recommendations could not have come at a better time to inform the U.S. position as a leader in combating AMR now. And as we gear up to renew our National Action Plan for another 5 years in 2025. It's evident that we all recognize that responding to AMR calls for an internationally collaborative approach. Antimicrobial resistant pathogens know no borders and can pose significant threats to global health security, economies, and our ways of life. Therefore, our response must be equally comprehensive and inclusive. The report that will be considered today represents the culmination of extensive research, rigorous analysis, and thoughtful deliberation by experts from diverse backgrounds. The strategic roadmap outlines concrete actions for U.S. government agencies to leverage their resources, expertise, and influence in advancing the global fight against AMR. Obviously, AMR is a key priority for the Biden-Harris administration, and the United States is committed to ensuring the momentum for action on AMR. We must commit to feasible actions and need to work with countries and international organizations to ensure implementation of sustainable solutions. In conclusion, I extend my heartfelt gratitude to each and every one of you on the Presidential Advisory Council for your dedication, expertise, and unwavering commitment to this vital cause, and for everyone who has taken the time to join in person and virtually. I'm sorry again that I couldn't be with you all today. Together, let us seize this opportunity to chart a course towards a future where AMR is effectively mitigated and the promise of safe and effective antibiotics endures for generations to come. Many thanks.
We thank Ms. Pace for her words, and hopefully she can join us in person at the next public meeting. So it is time, the moment you've all been waiting for. We finally finished our report for discussion. I'm delighted that the report from the Global AMR Working Group has been completed. They have their draft. It has been shared with all of our council members, and it is also available online on our website at HHS.gov/PACCARB. Today, we will be deliberating and then voting at the end on the proposed recommendations in the report. If approved by a majority, this report will be considered final and then transmitted to the Secretary for consideration, who will then in turn transmit it to the President. I will now pass it over to our Global AMR Working Group co-chairs, Drs. Plummer and Newland, but starting with Dr. Newland.
Thank you, Jemana. Thank you, everyone. And I'd like to just highlight first on the first slide. There I am. Freshly shaven head today, by the way. Will we show slides? Oh, here we go. All right. So, again, thank you to all, especially to our the staff that helped put this together. If you can go back to the first slide really quick, I want to highlight the title. I think it's super important. As we started the title, the PACCARB report, collaborative global leadership to combat antimicrobial resistance. I want us to keep in mind throughout the word collaborative, and you'll hear some of the foundational points of the report as we go forward. Next slide, please. So we were tasked in August of 2023 from the Secretary of Health and Human Services, Javier Becerra, who tasked the PACCARB to critically evaluate the U.S.'s role as a global leader in the fight against antimicrobial resistance. This task included identifying U.S. priorities for global engagement in the lead up to the UN, the United Nations General Assembly high-level meeting in September of 2024, where the focus will again be on antimicrobial resistance. The last time this was a focus was 8 years ago in 2016, which is the first time actually any antimicrobial resistance had hit that level. And so it's an outstanding opportunity for us, our country, to continue to be a leader and a collaborative leader at that. While identifying global priorities, the Secretary also asked PACCARB to evaluate Goal 5 of the current Combating Antibiotic Resistance Bacterial National Action Plan. Goal 5 focuses on activities of U.S. global engagement as the next iteration of the CARB National Action Plan is underway currently. The PACCARB has provided input on areas that can be updated or modified to continue the progress already made to 2025 and beyond. Next slide, please. In response to this task letter from the Secretary, the PACCARB went into action and stood up the Global AMR Working Group. Thank you to all. The working group met monthly from January to May of 2024. And during these sessions, we had closed-door presentations from key stakeholders to inform the development of the report in front of everyone today. In addition to the closed-door working group sessions, we had fabulous two public meetings that occurred in December of 2023 and again in February of 2024. Both of these meetings brought together key stakeholders to also inform the development of the recommendations report. The live cast, presentations, and meeting minutes from these sessions can be found on the PACCARB website under past meetings. Next slide, and I'll turn it to Dr. Plummer.
Thank you, Dr. Newland. So as Jason mentioned, our first public meeting was in December 20th of 2023, and that officially kicked off the information gathering to inform the recommendation report, along with standing up the working group. At that meeting, we focused purely on U.S. federal global activities, and we got updates from 5 federal agencies, including HHS, Office of Global Affairs, U.S. Department of State, USAID, U.S. Department of Agriculture, and the CDC. Out of that, we had several major themes emerge that came up during that meeting. One was the need to continued and strengthened collaboration between agencies on all foreign CARB activities. Secondly, we identified the need for sustained funding for all domestic and international CARB activities, as this is especially important as the CARB task force looks to develop the next iteration of the CARB National Action Plan. Continuing the fight against AMR is crucial to support advances made in public health, and funding should be commensurate with the enormous burden that AMR can have on intensifying other public health issues. And then third, we identified the need to advance R&D being a continued critical need in the fight against AMR. We need new drugs and new diagnostics, especially ones that are cost effective so that they can be better utilized and accessed in resource limited areas. Next slide. Our next public meeting was held in February of 2024 here outside of DC, and continued our information gathering activities by hosting the 24th public meeting. During this meeting, implementation of global AMR activities were asked to be spoke about among the work they do and the major gaps and needs still not being addressed to support the crucial work in combating AMR within the community. Out of that meeting, several takeaways also emerged. First, the need for increased access across the board with a special focus on resource-constrained areas. Secondly, we identified the need for improving communication and messaging around antimicrobial resistance to promote awareness, empowering the patient through information, and to increase buy-in from local and international policymakers. And third, including and better incorporating behavioral science into all global and domestic AMR activities to improve intervention outcomes and address many of the root causes of antibiotic misuse. All right, next slide. So out of that has come what we are bringing forward today as the report on Global AMR Working Group, along with the recommendations. Again, this came from input from the working group meetings, the public meetings, the speakers we brought into both our public and administrative meetings. Okay, next slide. So over the next couple of slides, briefly, myself and Dr. Newland will give the kind of high-level report structure and the recommendations, and then we will open it up for deliberation. The report and recommendations are organized into 4 main priorities for global action identified by the Global AMR Working Group. The U.S.-specific recommendations are then meant to further efforts under each of these priorities. The 4 priorities include preventing infections. Second, improving global awareness of AMR. Third, globally responsive development of AMR products. And fourth, equitable access to antimicrobials, vaccines, and diagnostics. However, those priorities and the recommendation within them alone do not address all of the current gaps in our global fight against AMR. Therefore, the Global AMR Working Group also put forth additional foundational concepts and a call for future action. Those foundational concepts that should be incorporated in all domestic and international AMR policy moving forward include clearly defining AMR, using the principles of plain language, developing science-based metrics and monitoring of activities, keeping the focus of AMR activities on local needs, and taking a leadership position on promoting global targets. The Global AMR Working Group also reinforced previous PACCARB recommendations from their 2019 report. Priorities for the National Action Plan on Combating Antimicrobial Resistant Bacteria 2020 to 2025 under future actions. In 2019 and now, the PACCARB acknowledges the need for sustained funding stream at the executive level, in addition to a singular ambassador who can be the face of AMR in all U.S.-related activities. While aspirational, the PACCARB reaffirms this recommendation as a way to ensure consistent funding of CARB-related activities and to solidify a truly One Health message for clear communication. Importantly, we recognize the importance of that individual as having expertise across all of the areas of One Health. In the next slide. So, our global priorities. These 4 recommendations elaborate on the 4 global priorities outlined in the previous slide. While noted as recommendations, these 4 priorities are meant to offer guidance on U.S. positioning to ensure continued leadership internationally in the fight against AMR. There's many activities and actions that can be taken under each of these priorities and beyond. However, it's the belief of the working group that these are necessary foundational concepts that must be met. In addition, these priorities are not presented to you as operating within a silo. All of these priorities impact each other, cross-cutting the One Health spectrum. Preventing infections cannot be achieved without spreading awareness of infection prevention principles and ensuring access to basic public health needs, such as clean water. Awareness of AMR is inconsequential if it does not allow for meaningful solutions to complex AMR problems, such as access and antibiotic pipeline. Incentivizing the AMR product pipeline, as well as developing globally responsive markets, can only be achieved with commensurate access, especially in low resource areas. And finally, access to the right treatment and the right time is not achievable without the right diagnostics and products available, in addition to awareness of how to best utilize the tools we currently have. In this way, these principles are all necessary to achieve meaningful change in the global fight against AMR. It is the Global AMR Working Group's belief that these priorities also should inform the U.S. position at the upcoming UN General Assembly high-level meeting on AMR. And now I'll turn it back over to Dr. Newland for the recommendations at the national level.
Yeah, next slide, please. Thanks, Paul. So under each global priority in this report, the Global AMR Working Group, our global working group, also put forth United States specific recommendations, actions U.S. federal agencies could take to further each global priority. And then these recommendations are also presented for consideration during the next iteration of the National Action Plan. I personally, as a pediatrician and a pediatric infectious disease physician, is very excited about the working group's efforts toward putting forth preventing infections. While we have discussed it in the past, it is a major focus, both globally as the original global recommendations, but also at the U.S. specific. And you can see in these, while we need to work on this domestically, we need to support the implementation of prevention initiatives for decreasing infections in low and middle income countries by developing guidances on program design and deployment for preventing infections, as well as with vaccines and other efforts. We also have to continue to make sure we include a One Health approach, and that's taking across the current and future international efforts in preventing infectious diseases, biosecurity, and AMR reduction activities. And again, the vaccination needs not to only be for human medicine, but additionally in veterinary medicine, so that we can continue to help in the protection and fight against AMR. Next slide, please. Awareness. Thank you, Mr. Graziano, for the amazing video and the efforts you're doing to help us in our efforts toward awareness. I think he highlights this well, and it is important that we continue our efforts in many facets for awareness. An important note within each of our U.S. specific recommendations is again given towards inclusion of animal and environmental health. We have made progress in this fight over the past 10 years, but it's important to note that there are still many gaps to improve our collaboration in the One Health approach and across the environment. I think it's also important that our awareness has to link to other issues, the global issues of our day, climate change, continued conflicts across the world, all impact antimicrobial resistance. We all feel that. We all see that. That will matter, and you can see in that first recommendations, connect the issue and impact of AMR to key national priorities in human, animal, environmental health, food security, and economic development. We have to link to greater issues so that AMR is further noted. Next slide, please. Globally responsive development of AMR products has been a key facet of our efforts with PACCARB for years. We keep talking about the need for more products. We will keep continuing, or we will continue to need to talk about these issues. As was stated in Maddie's story, she was down to one antibiotic because of intolerance against MRSA. That happens all the time. Imagine if you only had one antibiotic and you were intolerant to said antibiotic. You no longer have an antibiotic. We need more products, whether that's antimicrobials, vaccines, innovative issues, or innovative products. Those are needed. And I think the recommendation, we implement domestic policies that support market-based incentives for product development to demonstrate their effectiveness and to award innovation while supporting programs that pilot similar incentive models in partner countries. We, as a high-income country and others, will have to lead these efforts. We have to be on the forefront of this, and that has to be continued recommendation that will be coming from PACCARB. And we have to support the research and development for animal, crop-specific diagnostics, antimicrobials, and other products as stated. Next slide, please. And maybe it should be the first one, usually, is equity. We have to have this equitable access to antimicrobials, vaccines, and diagnostics. We just talked about the development of antibiotics, but sometimes people can't even get what we have in their countries or in areas. Equity has to be forefront and thought of. Access to the right drug at the right time across the One Health spectrum cannot be stressed enough. That includes infection prevention, that includes awareness, that includes new products, that includes antimicrobial stewardship efforts. All have to be a major part of this priority. Stewardship, which is the thing that I am near and dear to my heart, has to be reinforced throughout this and done in a way that incorporates all of it, not just taking away, but making sure people have it. Use it right, use it appropriately, use it for those who need it. This will help us in this efforts toward global antimicrobial resistance. Next slide. All right, the fun part. We will now move to council deliberations with vote, which will be moderated by the wonderful Dr. Jomana Musmar. During this time, we truly encourage you guys to please provide your feedback and input, as we will be able to make live edits to the draft, but also we can hear what resonates with you all. You all have spent countless number of hours working on this. We want to hear your voices as we go through these final stages of this amazing report. Dr. Musmar.
Thank you, Dr. Newland, and thank you, Dr. Plummer, for presenting the report. I'm just going to remind council members for the purposes of the live stream as well. If you have a comment, question, want to say something, please be sure to lift up your name tent so we can put the focus on you. And for the record, any edits that are made will be done live by the lovely alternate DFO, Ms. Sarah McClelland. So if we have any changes, we will make that for the record, and she will restate the statement if any changes are made. But I will now open the floor to our council members to make a statement regarding the report, and I'll start with Dr. Virginia Fate.
I had a question and a comment for consideration or maybe explanation of what the deliberations were about. The first is, I have it on page 16. There's a parenthetical about the necessary use of antimicrobials. So the statement, the question, or excuse me, the sentence is, prevention combats AMR on multiple fronts, reducing the use of antimicrobials, both appropriate and inappropriate. And I'm just wondering whether we actually need that statement.
What would you like to change it to?
I would just take it out, and I'm just curious whether there was a deliberation on the working group's part to make sure and include both appropriate and inappropriate as qualifying the use of antimicrobials.
So you're proposing to strike the sentence?
But I was curious if there was some reason to include both of those.
I'll just make one comment to that. Thank you for bringing that up. I think the reality of it is if you use an antimicrobial, whether it's appropriate or inappropriate, you are putting pressure of resistance. So if you never have to use it, you are in the best off. So if we can prevent infections, that case. So while I think it's okay if we want to strike it, I do think that the point being, we keep people healthy. We keep us from needing those antimicrobials, whether it's because we're vaccinated and we never show up at the doctor because we have a runny nose and cough, or it's because I didn't get injured from whatever, and I don't need that antibiotic because now I'm infected, which are appropriate uses. We will help combat antimicrobial resistance. So that's kind of, I think, the sentiment for that statement.
So what I will ask for the purposes of everyone, since not everyone has the report in front of them, Ms. Sarah McClellan, could you please read the sentence before and after with the strike included?
Sure. Just to clarify, would you like to strike what's the entire sentence or just what's in the parentheses?
Just what's in the parentheses.
Okay. So the sentence before starts, keeping humans, animals, and the environment healthy through the prevention of infections, including those caused by antimicrobial resistant pathogens, is an essential component of the fight against AMR and must be a priority both for global and U.S. action. Prevention combats AMR on multiple fronts, reducing the use of antimicrobials, both appropriate and inappropriate, and reducing the transmission of antimicrobial resistant pathogens.
So
that's with it in.
That's with it in, and now without it?
Would you like the sentence before as well?
The sentence itself.
Okay. Prevention combats AMR on multiple fronts, reducing the use of antimicrobials and reducing the transmission of antimicrobial resistant pathogens.
So the qualifier is now gone. Does anybody have a problem with taking out the parenthetical? Dr. Huang.
I agree with Virginia that it took, when I first read it, it gave me a little bit of pause, but I actually liked it. I actually thought that is what prevention is supposed to do. It's supposed to stop all infections, and it should stop the use of appropriate antibiotics for infections because hopefully the infection never occurs. So I don't know if it should be rephrased, but I actually think the sentiment is correct.
Anyone directly? Dr. Kwan, did you have a response for this particular comment? Okay. Dr. Newland, did you want to respond?
Yeah, I'll just propose maybe the way to do this and say reduce all antimicrobials. And if it's the inappropriate and appropriate that gets people hung up, then you just says it prevents all antimicrobials if that's where we want to, if that's where people are getting hung up.
Yeah, I wonder if I think that there's so much focus in stewardship, and I don't know if it's the lens of those of us who do stewardship is always on the inappropriate. I actually think it would be really nice to have a very clear statement that preventing infections in the first place will prevent the use of antimicrobials for infections that can lead to pressure for resistance.
I'll jump in because this relates to the
Go ahead,
discussion.
Dr. Dennis Dixon.
I wonder if you just put unnecessary in front of use where you said reduce antimicrobial use, because you don't want to reduce it if it's necessary. And that gets away from appropriate, inappropriate, which we might have stigmas about, but it's just unnecessary antimicrobial use. Add one word to what was just read to us.
So, Sarah, could you please reread it with inserting just unnecessary without the parenthetical?
Actually, can I just add one more suggestion?
Sure.
Instead
Dr.
of saying,
who's speaking?
Oh, hi.
HRQ.
Instead of right before the parenthetical, you talk about the use of antibiotics. Maybe change that to the need for antibiotics, just for consideration.
I will read it both ways. So first with Dennis's edit and then with yours. Prevention combats AMR on multiple fronts, reducing the use of unnecessary antimicrobials and reducing the transmission of antimicrobial resistant pathogens. And then prevention combats AMR on multiple fronts, reducing the need for antimicrobials, and reducing the transmission of antimicrobial resistant pathogens.
Dr. Huang, did you have a response?
Yeah, I think the thing that's missing in that sentence is why is the prevention of infections in the first place. So I wonder if we can just say, go back to the reducing the need for antimicrobials by preventing infections in the first place. I wonder if that might just help set the stage. I know the sentence after that says preventing infections leads to a healthier population, but the juxtaposition between those two things need to come very close together. The prevention of the need of antimicrobials is because you prevent infections in the first place.
Dr. Fate, does that address your concern if we added that qualifier after?
Yeah, I think I was getting hung up on the why do we need to say appropriate and inappropriate. It's all about just the need or the use. So I actually like the need.
The need. So we're going to stick with the need for antibiotics and why we need them as it relates to prevention, just to clarify. And we are taking out the parenthetical that includes appropriate and inappropriate. Any other comments regarding that sentence? Thank you, Dr. Miller. Thank you, Dr. Dixon, for those options.
I'll just say that I really like the way that it's newly phrased, because this rationale for why we're actually reducing infections overall is, I think, really important to include in that.
Fantastic. All right. Thank you, Dr. Srikantia. Anyone else? Going once, going twice? Oh, Dr. Lewin. No?
I just want to make one other comment. I think I failed to highlight the importance that is brought up in our recommendations around social scientists. Sorry, Dr. Simzak. I think that is a key, the behavioral change that is necessary for us that we need to be investing more in these individuals to be a part of our efforts in awareness, development, implementation of such. I was going to say we need a clone Dr. Simzak. We need a lot of more folks that involved. Thank you. So I just want to make sure that the PACCARB, and I'm sorry, Dr. Kwan, I think was going to speak. Sorry.
So I'd like to make a comment in support of the prevention piece that we're discussing here. So as an ID physician who cares for immunocompromised patients like Maddie, except in adult form, it took me back to a time when I was a medical student taking care of a liver transplant patient who actually went into hospice because this person had an untreatable disseminated pseudomodal infection. And so to me, it's not a question of if we will get to the point where we lose antibiotics. We have already gotten to that point in some situations. And so I wanted to also just focus in on knowing that that prevention piece that we're recommending is of utmost importance, because it's not just about preventing the development of resistance through stewardship, et cetera. It's about preventing the person from becoming infected and then infected again and again. And so I'm really, really happy that this is so strongly highlighted here.
Thank you, Dr. Kwan. Any other comments from our council members regarding that sentence itself? Dr. Marks, did you have just a general comment or regarding this? Different comment. All right, let me just do one more scan. Anybody else? Okay, so just confirming what the change has been. There hasn't been any sort of objection regarding that. So we will make the change and include that in the draft before its transmittal. Any other comments? And I will now turn to Dr. Oh, Sarah, could you read the final statement, please?
Prevention combats AMR on multiple fronts, reducing the need for antimicrobials by preventing the infection in the first place and reducing the transmission of antimicrobial resistant pathogens.
All right. Everyone good with that? Fantastic. All right, moving on. Dr. Fay, did you have any other comments?
Yeah, I had a completely separate, this is page 18, talking about vaccines. There's a statement about animal health, ensuring widely adopted prophylaxis for vaccine preventable diseases. And then the next sentence, it says, low efficacy of some veterinary vaccines makes vaccine prophylaxis less desirable than antimicrobial treatment, blah, blah, blah. And that is true, but I think there's the additional series of factors, I suppose, the economic or other drivers of vaccine use that either the vaccine is either not incentivized or is disincentivized, even if it's effective. And so the uptake of vaccines, even effective vaccines, is the problem as opposed to the efficacy itself. And I'm not sure exactly what to do with that, but I wanted to bring it to see if that had been discussed, because it's not just about effectiveness of those vaccines that are currently available or might become available.
So just to clarify and summarize what you would like to see further elucidated in that section, you want to make sure that the economical factors are also part of the impact as it relates to decision-making and use.
Yeah, it may be economic and maybe other factors related to incentivizing or not, or disincentivizing the use of vaccines. And I'm not just talking about vaccine hesitancy here. It's more about if I recommend vaccination of cattle before they are transported to a feed yard to help prevent bovine respiratory disease on arrival, those products may work fairly well, but if I'm not incentivized as the person selling those animals to have vaccinated them before they get on the truck, that means I'm not going to do it. And it's not about the effectiveness of the vaccine. So it is somewhat economic incentive, but it's not necessarily. So yeah.
But ultimately the incentive is economical, right? Because they want to make sure that they're either saving time or money.
In that case, yeah.
Right?
In that example, okay. For sure.
So you would like the inclusion of economic factors among others?
Yeah, maybe economic and other drivers of vaccine use, regardless of efficacy. Anybody else got a way to say? Are you, Joni? You're nodding your head.
Yes, Dr. Sheftel.
I fully agree with you, Virginia. I took pause when I saw that sentence, but I didn't have as good a way of thinking about it as you just verbalized. There are a lot of factors, and low efficacy is only just one of them. In fact, most veterinary vaccines are efficacious, or they wouldn't be on the market. So I think a little wordsmithing there is what we do need. I'm sorry, I nodded my head and you said something because I don't have it in my head yet what we should say, but I just want to agree with you.
Okay. Dr. Plummer may have a suggestion on the.
This is on the fly a little bit, but so what if we did something like many factors, including low efficacy of some veterinary vaccines, comma, economics, comma, and in some cases, lack of incentives makes vaccine prophylaxis less desirable than antimicrobial treatment that is both inexpensive and readily translates to tangible results for producers. Did you get that, Sarah?
Can you, well, before we have you reread it, any other comments regarding this sentence change? Dr. Wong?
This is a question out of ignorance. When I read this, I had the impression that we thought that the vaccines for veterinary use were so low in efficacy that antimicrobial use should be done. And if that is not the case, I suggest we change the language of low, because from an outsider, it just read as, why are we bothering?
No, it's in comment because it's important to get the other domain's perspective when they read this.
That's exactly why I flagged it, because I was concerned that that would be the interpretation.
I think this comment came out of one of our presentations from folks working internationally, where they were specifically talking about vaccines that had, in that case, no documented efficacy. And so that was a challenge for them to promote that, obviously. So I think that's where this comment kind of originated from, but maybe wasn't recontextualized in the context of a broader, but.
Dr. Patel.
I also have a naive comment from experience in the health field. Is there any role for guidelines, recommendations, regulation, aside from incentives in this area? And it's not my area, so I don't know.
There are vaccination guidelines for animals, at least in companion animal.
Dr. Burbick.
I guess I would still advocate for keeping low efficacy in there. I think we do have considerable problems with some of our vaccines and also perception that they don't work great. And I don't think it's just an international problem. And I think the regulatory environment is better now around veterinary vaccines and that they need to prove some level of efficacy, but historically that was not the case. Can't remember what year they actually decided that they had to prove efficacy for veterinary vaccines, but it wasn't that long ago. So I think we have a lot of vaccines that historically are on the market that might not be super amazing. So, and I think it's something that we need to highlight, because I think if we want to use vaccines and we want to advocate that they're going to be an important part of, any preventive program, when I talk to veterinarians, especially in animal medicine, they use them, but acknowledge that they don't think that they do a whole lot, especially in certain areas. So for certain disease conditions. So I think we have to take that into account, especially when we have, certain areas of practice that put a lot of, I would say, infectious pressure on animals. So I think it is an important consideration that needs to be, I would say, like, better funded for sure. So I think it has to be in there. At least I would advocate for that.
Thank you, Dr. Berbick. I want to turn our attention to Dr. Lobers. You're on the line.
Yeah, I like Dr. Plummer's suggestion to be inclusive of a lot of these factors. I was actually pretty strongly a proponent for including the low efficacy, because that, and kind of in support with Dr. Berbick said, we do use the products, and they go through a USDA approval process, and they have for a long time. That the label claims were cleaned up. I think it was about 5 years ago, and they had tiered labels, and now there's a single label system. But they kind of ranged from prevention of infection, which is the most difficult bar to pass, to aid in control of disease, which is a pretty low bar. And so it's not just the vaccines are bad. I think in some situations, Dr. Fate gave the example of, administering a vaccine prior to shipment to a different segment of the production system where they're going to experience that disease challenge. Well, that's probably not fair to the vaccine, right? We know that they take time to stimulate the immune system. And so expecting a vaccine response in 24 hours is not likely to happen. And so I think some of it is the vaccine, some of it is the way we use them, and then some of it is just the disease challenge. And so I think we need to include that as one aspect, but I totally agree. There are financial aspects that come into play when making those decisions. There are logistical considerations that come into play. So I think all of that needs to be captured.
Thank you, Dr. Luber. So far the consensus is to keep low, but to also include the other factors as part of the sentence, as mentioned by Dr. Plummer. Dr. Wong, did you have a response?
Yeah, I just wanted to make a comment about our perception about vaccines. I find that when we talk about prevention, if you can do something that is 15, 20, 25% prevention, we declare an enormous win. But the human sentiment about vaccines is that if it's not 80% effective, people feel like it's not worth it. If it's 30% effective, it's probably still cost effective in a lot of places. And so I find that I'm having a hard time with the low, because sometimes low at 20 or 30% is still cost effective. It's our sentiment that gets in the way. So I just want to make sure that when we think about the value of vaccines, we need to reframe it often. And so I'm not sure this is the right place for it, but I find low puts it can be low and still cost effective. And low doesn't have to have the deep negative perception about the value of a vaccine.
We appreciate that comment, Dr. Mon. Thank you so much. And I think that particular nuance requires probably further conversation as it relates to human versus animal health. I'm sure it has different definitions and values, regarding that. Dr. Patel, did you have a comment regarding this? All right, Dr. Plummer.
I was just gonna say, if low is problematic, I personally like low, but if low is problematic, we could consider switching it to variable efficacy, and broaden it out a little bit to say, because we do have some efficacious vaccines, and so, modify the sentence that I said to include that and just change low to variable efficacy.
Any objections to including variable instead of low? Okay, Dr. Zachman.
Thank you very much. I was actually going to say about the same, but I was going to suggest a part of that. I really like Dr. Huang's point of cost efficacy. So an alternative will be to say, still here. So
okay. And yeah, and the rephrase, hopefully it'll capture it and Sarah can read it and verify for us if it addresses that. Do we have any other comments regarding this? Oh, Dr. Sheftel.
As long as we're taking this sentence apart, there are veterinary vaccines for bacterial pathogens for respiratory disease, but just like in humans, most vaccines are against viral pathogens. And so if you don't vaccinate, then you ship cattle and they all get sick, and you treat them with antimicrobials, you're still worse off than if you vaccinated them. So that readily translates to tangible results for producers. I mean, you're still going to have death. You're still going to have really sick animals. It's not a tangible, it's not an excellent result to have the animals get sick and then give them antimicrobials. So if we could just drop that last phrase, as long as we're tearing this sentence apart. Does anyone else see that?
Could you reread the phrase?
The phrase is readily translates to tangible results for producers.
I can read the whole sentence
Could
with
you please,
the
Sarah?
edits, and then we can see how that fits. Many factors, including variable efficacy of some veterinary vaccines, economic drivers, and lack of incentives, makes vaccine prophylaxis less desirable than antimicrobial treatment that is both inexpensive and readily translates to tangible results for producers.
That's with, and now without?
Many factors, including variable efficacy of some veterinary vaccines, economic drivers, and lack of incentives, makes vaccine prophylaxis less desirable than antimicrobial treatment that is inexpensive, I guess would be how we, because it's both inexpensive and readily translates
Dr.
to tangible results.
Thank you, Sarah.
I will change then that to that is cost effective and delete the rest.
Dr. Wong?
Can I ask a question? I agree with you at the ending because I think both will have tangible results of a vaccine or a treatment. I think the part that I'm stuck on is that I think a lot of people don't like upfront costs. So prevention is upfront. And when you are treating something, even though it costs more, you feel like you have to do it. So you have a tangible result. So is the problem here that we're saying that the problem is that in agriculture, there's no desire for upfront protection, even though they might be paying more later for therapy. The sentence reads as if it's more cost effective, definitively more cost effective to give antimicrobial therapy later. But I think that's not what we're saying. It's the decision making to give an upfront prevention cost when you're hoping you don't need it versus paying out when you know you need it. So maybe there's a way to edit that to not suggest that prevention is not tangible for a benefit.
Yeah, I wonder if we could just do desirable that antimicrobial prophylaxis less desirable that antimicrobial treatment in some cases and delete the remainder. Right. Yeah. I mean, this impacts companion animal as well, for sure. Same sort of sentiment.
Many factors, including variable efficacy of some veterinary vaccines, economic drivers, and lack of incentives, makes vaccine prophylaxis less desirable than antimicrobial treatment in some cases.
Are we good? All right, fantastic. Without any objection, we'll continue with those edits in that line. Dr. Lynn Marks.
Thank you. Sarah, it has to do with the recommendation under the R&D section. I think the language used was award innovation. The challenge and the problem is rewarding innovation. The pharmaceutical industry is leaving, venture capital is leaving, talent's leaving. It's because the commercial model doesn't work. So it's rewarding that innovation rather than awarding.
Dr. Marks, could you tell us what page number you're referencing?
No.
We'll do a control F.
It was on the slide.
It was on the slide.
It's page 24, I believe.
Could you just read the sentence that?
Yes, give me a second to find it.
All right. Sarah will find that. Let's go ahead and get Dr. Patel's comment.
Page 25, top of the page.
Page 20
says implement domestic policies that support market-based incentives for product development to demonstrate their effectiveness and award, I would argue, replace it with reward innovation while supporting programs that pilot and similar incentive models in partner countries.
In the recommendation itself.
Yes.
Any objections to replacing the word award with reward in the recommendation on page 25? All right. Thank you, Dr. Marks. Dr. Patel.
Yeah, this isn't a line edit. I just wanted to commend the council on the recommendation for a federal spokesperson. And I wanted to specifically call out to the White House and HHS that this recommendation has been made before. And I think that this would be really important to really coordinate and understand all the global AMR efforts. And I think it would be great if we could really follow through on this recommendation.
Thank you, Dr. Patel. Yes, this was made in 2019, and actually it was Dr. Eileen Marty that made the recommendation then when we had our recommendations for the National Action Plan back then. All right. Any other comments or questions? Oh, Dr. Pantaleon.
Just a quick comment on the page 18, defining AMR. I think we're talking about the WHO list of priority pathogens. And that list, I think it has been released this week. So we could change maybe the language there, maybe put a reference to it because it's talking about future release.
It's an easy change. Thank you, Dr. Pantaleon. We can make sure that we footnote and reference the new WHO priority pathogen list that was just recently released. Thanks.
Yes, so focus on page 14 in the Center on Global. Furthermore, some experts have suggested that targets be crafted with the assistance of an independent panel that focuses on the science behind the metrics. And that is something that the recommendations actually have first come from the UN Interagency Coordination Group on AMR, and there's been a subsequent recommendation from the Global Leaders Group on AMR around this as well. So I believe that that statement could be strengthened to indicate that there is a broader base of recommendation, that there should be use of an expert panel. And maybe if we change the text to say that experts and bodies have suggested that targets be crafted with the assistance of an expert panel focusing on the science behind the metrics.
Thank you, Dr. Jinks. I just make sure that Sarah was able to hear your line edit.
Furthermore, some experts and international bodies have suggested that targets be crafted with the assistance of an independent panel that focuses on the science behind the metrics. Is that?
So the edits I would suggest is dropping the sum and simply say experts. And you could reference the GLG. It's referenced in the paragraph above. Have suggested targets be crafted with the recommendations of an expert panel focused on science behind metrics.
Furthermore, experts and the GLG have suggested that targets be crafted recommendation of an independent panel that focuses on the science behind the metrics.
Can we replace independent with expert?
Yes.
How many experts do we have so far?
We now have 2 experts in that sentence.
Could you just reread it one more time?
Furthermore, experts and the GLG have suggested that targets be crafted with the recommendation of an expert panel that focuses on the science behind the metrics.
Did you want advisory panel? Isn't that what the yes, formal, yes, advisory panel, please.
Advisory. Furthermore, experts and the GLG have suggested that targets be crafted with the recommendation of an advisory panel that focuses on the science behind the metrics.
And we'll be sure to footnote the GLG and the other bodies that have recommended that as well for reference, since we are including somebody else's recommendation as part of the narrative. Does that address your concern, Dr. Jenks?
Yes, thank you.
All right. All right, folks. Any other comments, questions, concerns, line edits? This is the time, or forever hold your peace. Oh, Dr. Srikantia, go ahead.
No, it's fine. Thank you. I actually just wanted to make a comment on 2 things that I think are really well highlighted in this report that I hope those who read it actually take attention to. The first, which I think that if we actually prevent infections, we're going to prevent the need to use antibiotics altogether. And much of the consequences of use and overuse, whether appropriate or inappropriate, is addressed by prevention. The second is the highlighting not only of innovation, but really tying it to access. And I think in a report that has a significant focus on global health and global health needs, both of these elements are really critical to actually make progress. So I just wanted to underscore that fact and really think that it's a good achievement and a good consensus that we've come to highlight them as we have.
Thank you, Dr. Srikantia. Any other comments before we turn to vote? Oh, Dr. Shawar.
Yes, thank you very much. On page 28, the top of the page, globally relevant procurement systems, and the paragraph discusses a lot about diagnostics and therapeutics. And at the end sentence, it stops and says about market access to novel therapeutics. So somewhere here needs to be added diagnostics and perhaps maybe even vaccines. Diagnostics is mostly covered below that and diagnostic stewardship. So if I were to suggest here something at the end, would say access to novel therapeutics and appropriate diagnostics, about that as well, the footnotes.
Thank you, Dr. Shawar. Could you add therapeutic diagnostics to therapeutics, please, Sarah?
This approach could expand markets, drive production need and associated supply chain demand, and support equitable access for LMICs, which have the highest resistant rates and clinical needs, but have historically been excluded from market access to novel therapeutic and appropriate diagnostics. Is that the correct sentence?
Any objections to that addition? No need for appropriate diagnostics.
Diagnostics.
Any other comments? I'm doing a full scan. No? Going once? Going twice? All right, we'll transition now to vote for our SGEs. When I call on your name, please let me know yay or nay for transmittal of the report as is to the Secretary of Health and Human Services. We'll start with Dr. Plummer.
Yay.
Dr. Newland.
Yay.
Dr. Black.
Yay.
Dr. Burbick.
Yay.
Dr. Fate.
Yay.
Dr. Long.
Yay. Yay.
Dr. Kwon.
Yay.
Dr. Lubers.
Yay.
Is he on the screen?
Yeah.
Oh,
Yay.
yay. Thank you. All right. Dr. Marks.
Yay.
Dr. Nahum. Mr. Okay, you can be Dr.
I know I've been called doctor before, but I'm not. Yay.
Dr. Patel.
Yay.
Dio.
Yay.
Dr. Sheftel.
Yay.
Dr. Simzak.
Yay.
And Dr. Whittam.
Yay.
All right. Chair, go ahead. And...
With that, we have unanimous approval. Thank you very much.
All right. All right. Well, congratulations, Council, on your 12th report thus far. Once the staff is able to finish all of the amendments and finalize the report, it will be posted online and transmitted to the Secretary of Health and Human Services, Javier Becerra. Now, I have the pleasure of introducing Amanda Disick, who is the Senior Vice President for Public Policy and Government Relations at the Infectious Diseases Society of America, IDSA, which represents over 12,000 ID physicians and scientists. Amanda oversees IDSA's Public Policy and Government Relations Department with responsibility for policy development and advocacy on IDSA priority issues, including antimicrobial resistance, the infectious diseases workforce, pandemic preparedness and response, immunizations, federal funding, and other issues relating to public health and biomedical research. Welcome, Amanda.
Thank you so much for having me. I am excited to talk with you all today about the infectious diseases workforce and the workforce that is so critical to have on the ground in our communities and our healthcare facilities to effectively combat antimicrobial resistance. Next slide, please. So I wanted to start off by first thanking you all for recognizing the importance of workforce as kind of one of the key pillars that we need in order to effectively combat antimicrobial resistance, and explicitly calling it out in the report that you all released back in March of 2023. Next slide, please. So as a quick refresher, this is the recommendation that you all included in that report to bolster the workforce. And I really do want to make clear when we talk about workforce, even though IDSA's membership is largely infectious diseases physicians, the workforce is really infectious disease physicians, ID pharmacists, infection preventionists, clinical microbiologists, and other clinical laboratory personnel. It's really a team-based approach, and we reflect that, and that's something that we really try to be thoughtful about in all that we do around the workforce. We were also very excited that you explicitly called out the importance of funding for the new Biopreparedness Workforce Pilot Program. This is a pilot program that was authorized, meaning it was signed into law, but it has not yet been funded. This is really critical for incentivizing healthcare professionals to first choose D, and to second, work in the areas where they are most needed. And it would incentivize that by offering up to 3 years of loan repayment for service as an ID professional. And again, that could be ID physician, ID pharmacist, clinical lab person, infection preventionist, and so on. And to work in an area that's been designated by HRSA as a health professional shortage area, medically underserved community, or certain federal facilities like VA hospitals, VA clinics, Ryan White clinics, community health centers, and so on. Next slide, please. So I wanted to highlight why it is so important to invest in this workforce. And it's because we have a really critical and frightening shortage. This map shows you all those white areas don't have any ID physicians. And the red areas have some, but not enough. So we also know that there are shortages like this across the other areas of the broader ID team. Next slide, please. Next slide, please. There we go. So not only do we have a workforce shortage currently, we're setting ourselves up for an even bigger workforce shortage because the need is increasing as care gets more complex, as we have more people who are immunosuppressed for a wide variety of reasons. There is greater need for people to prevent, diagnose, and treat these very complicated, often drug-resistant infections, and we are training fewer and fewer people. So in the last year's match, we only were able to fill 51% of adult infectious disease training programs across the US. The match numbers for pediatric ID were even lower. And this is not a problem across all other areas of medicine. The vast majority of other specialties fill regularly 90% or more of their training programs. So anyone who tells you, oh, it's a problem across medicine, it's not. It is a much more serious problem in infectious disease. So why do we have that problem? At IDSA, we have spent a lot of time, a lot of resources talking with medical students and residents, really trying to research and understand what leads to their specialty choices. And one common theme that we hear again and again is medical students and residents saying, oh, I love ID. ID is so interesting. It's so intellectually stimulating. It's so rewarding. They're the best teachers. I had such a great mentor. Oh, but I can't choose ID. I can't actually go be an ID physician. Can you see the next slide, please? So one of the big reasons why people can't choose ID is the financial barrier to going into the field. Medical students on average are coming out of their training with about $250,000 worth of student debt. And it's very hard to convince them to go into the third lowest paying specialty. I want to point out infectious disease is now below internal medicine and family medicine. So what we're essentially telling people is you could go right out of your residency and be an internist, be a family medicine doctor, and make more money, or you could go and do another 2 to 3 years to become an ID physician and earn less. And that's really, really hard to convince people to do, especially when they have that heavy medical student debt already hanging over them. And this is really just because the way our healthcare system is set up, we don't value ID. We don't value the expertise that they bring. We don't value the incredible positive effects and impacts that they have on patient outcomes. We value procedures. And that's sort of how we landed here. Next slide, please. So I don't want to be all gloom and doom. There are solutions. We talked about one of them, the Biopreparedness Workforce Pilot Program, that loan repayment program that we desperately need to get funded. NIAID is already doing really great work to train the next generation of ID physician scientists. That's critically important. We want to see more investment there. We also are doing a lot of work on the reimbursement side to really try to help make the physician payment system adequately and appropriately value ID physicians and their expertise and the value that they bring to patients in the healthcare system. Next slide, please. So I wanted to talk a little bit about what IDSA is doing on the reimbursement side. We have had a lot of discussions with CMS over the years about these challenges, and what they kind of said to us in recent months has been, tell us more, really get into the nitty gritty. What are the specific things that ID physicians are doing that are not adequately valued, adequately reimbursed by the codes that we currently have? And so as we went through with our members and worked on these long lists, we realized they fit into kind of these 4 major buckets. And a lot of them really directly, closely relate to the things that you all talk about that we need to do for AMR. So complex ID prevention, right? If you're taking care of a patient who, is a transplant patient or is getting cancer care, or for some other reason is very, immunologically suppressed, they need much more intensive prevention services. Complex diagnosis, particularly if someone has a lot of different chronic condition, it's, a lot more goes into that than simply running a test down to the lab, seeing the results and going forward. complex antimicrobial therapy, really trying to figure out these multi-drug resistant infections. What can you do? Really thinking about the local resistance patterns, thinking about not only the impact on that patient before you, but the impact on the broader community of patients. And then more broadly, that complex ID care management that so often involves coordinating with a transplant team, an oncology team, orthopedic surgeons. I could go on and on. So we shared some draft code descriptors and we said, okay, CMS, here it is. Plop it right into the next Medicare physician fee schedule rule. And we know that that often serves as the sort of the basis, the example that private insurers and others often follow. We also shared ways that these could be broadened out if they wanted to do something that was more broadly related to complex care and not ID specific, tried to kind of give them a few different options. So these are some of the things that we're looking at. I also want to say that we all recognize within IDSA these different solutions that we're working on. There's not one silver bullet. And we know that more than even just the few things I talked about today is absolutely needed. But these are some ideas that are gaining traction and some things that we think could be really meaningful steps forward. Next slide, please. So what can you all do? We would love to see where we potentially collaborate with a PACCARB. And I was thinking to something that Dr. Newland said at the beginning of the meeting, that the work that happens here matters. And he is absolutely right. And I've been really privileged to kind of watch PACCARB from the very beginning. The very first meeting. And I was thinking back to one particular example when we were trying to get the EMS to steward other organizations, and PACCARB did a letter explicitly piece why that was so important. And that mattered. And that led to CMS putting that condition for participation in place. It's now the law of the land. But we need a workforce in order to really make sure that stewardship and infection prevention and all these other important services are really carried out as fully and thoroughly as they need to be. So if you all are willing and interested and be willing to communicate with CMS and with OMB about the importance of improving ID reimbursement, as well as to communicate with HRSA about the importance of including funding for this pilot in their upcoming budget, which they are currently working on putting together. So these are our timely requests, and I really appreciate all of you taking the time to think about these issues and consider them. And we would, I think all of us at IDSA, and I know many of you are also IDSA members with your other hats, really appreciate any opportunities to continue engaging with you all and working with you on these issues and on the many other great pieces of work that you all are doing. So thank you so much.
Thank you so much, Amanda, for joining us and for sharing the work that IDSA is doing. And this is an administrative item that we'll take back for the council members to discuss and consider. Appreciate IDSA joining us today. And now we get to give you guys a 5-minute stretch break before we continue on with our panel. We are going to continue with the advocacy and the voice of the patient. And this time we have many voices. So please stick with us. Please be back in 5 minutes so we can start promptly at 11 o'clock Eastern time. Thank you.
Produced by the U.S. Department of Health and Human Services.